Good morning all. Welcome to the class on adverse drug reaction. Myself Dr. Padmanabha TS, Faculty of Pharmacology. So one of the preventable condition where patient can be prevented from hospitalization is adverse drug reactions. So if you are able to identify the adverse drug reactions in the initial stages, or if you are able to properly communicate with the patients while you are prescribing a drug, you can avoid many adverse drug reaction and you can prevent the hospitalization. And finally, very important thing is you can prevent the mortality from the drug they are administering. So welcome to the class on adverse drug reaction. So the objectives or the overview of this class is, at the end of this class, you should be able to understand the definition of adverse drug reaction, abbreviated as ADR. And you should be able to explain the types of adverse drug reactions. And also you should be able to understand the management of anaphylactic reaction. So what do you understand by adverse drug reaction? So adverse drug reaction, in simple terms, it is unintended harmful reactions to the medicines. It is the unintended harmful reaction to the medication which are taken at the normal or a therapeutic doses, which will be able to either prevent or to treat or diagnose the condition. So this 3 or 4 things should be there in the definition, that is unintended harmful reaction to the medication which are taken at the normal therapeutic doses, either for the prevention or the treatment or the diagnostic purposes. So broadly you can classify the ADRs into type A as well as type B adverse drug reaction. So let us understand what is the difference between the type A as well as the type B adverse drug reactions. So type A stands for augmented type of reactions or augmented effects. So whereas type B stands for bizarre effects. So when we compare these types of reaction, you'll come to know which is more dangerous and which is more safer. So type A, which is augmented effects, these adverse drug reactions are very predictable in nature and they are very dose dependent effects. And these incidents are very high. Type A adverse drug reaction incidents are very high. So these are the reactions which are more commonly seen in your practices, type A reactions. And the mortality rate is very low. Mortality rate is very low, and also you can expect these undesirable effects. So type A is, it is augmented effects, it is more predictable because of it is dose dependent. Incidence is very high, but the mortality rate is very low. And this type of reaction can be expected, undesirable. Next, coming to the type B reaction, where you can see that it is a bizarre type of reaction. It is a bizarre type of reaction and it is not predictable. We are not going to predict whether this drug causes a adverse effect or not. So these type of reactions are not predictable. We are not able to expect that these reactions will going to occur, and it is not dose dependent in nature. So please remember, it is not dose dependent in nature, and incidence are very low. Incidence are very low, but mortality is very high in case of type B. Mortality is very high, and it is unexpected, undesirable, and which is unexpected and undesirable. So which is the most common type of adverse drug reaction you are going to encounter in your day-to-day practice? It is your dose dependent predictable adverse drug reaction which is expected, and the mortality will be very low. It is a type A adverse drug reaction. So but type B, it is unpredictable, but it is not dose dependent. Incidence are very low, but if it occurs, the mortality rate is very high. So next we'll see the individual, what are the types of ADR which comes under these subtypes. So type A will have some of the examples and type B will have other examples. Let us see those examples. So whatever we call a side effects which occurs at the normal therapeutic dose, the side effects, the secondary effect, the extension of the effects, pharmacological effects, or the toxicity which occurs at the larger doses, they comes under the type A adverse drug reaction. So they comes under type A adverse drug reaction. So please remember, type A adverse drug reaction, you have a side effects, secondary effects, and toxicity. Whereas type B adverse drug reaction, you can note down that the hypersensitivity reactions, whenever the drug is given, any drug can cause adverse drug reactions, hypersensitivity reaction, either due to the chemical entity itself or due to the any excipients that they will be adding into the medications. And it can be due to the any genetic abnormality or genetic change in the person's DNA or the gene. And it can be idiosyncratic reactions. So type B, you have a hypersensitivity reaction, genetically mediated reactions, or due to the idiosyncratic reactions. So let us see these examples one by one. So type A, we have a side effects, so which is a undesirable effect which will be going to occur at a therapeutic doses. For example, if you give a paracetamol 500 mg, for which condition it is given? It is given in a conditions like fever. So some of the individuals, which is a normal therapeutic dose is 500 or to the 650 milligram, some of the individuals will going to experience nausea and vomiting. Some of the patients or the individuals will going to experience side effects of gastric irritation. So this can be a side effect which occurs at the therapeutic doses which is undesirable. So these are predictable, but these are undesirable. So you can predict this, but it is undesirable effect which is not required. So when you give a paracetamol, the desirable effect is to control the fever. So you are not expecting to the undesirable effect. So undesirable effect will be gastric irritation due to the decrease in the production of the prostaglandin secretion. So as you know that NSAIDs will going to decrease the gastroprotective prostaglandin secretion, that can lead to the gastric irritation when a paracetamol is taken in a sensitive individuals. So what are the other examples which we can quote? So other example is we have a dicyclomine, which is an anticholinergic agent which is used as antispasmodic to decrease the abdominal pain. So one of the desirable effect is to relieve the colicky pain which is arising from the abdomen, but undesirable effect is all the anticholinergic drugs, you know that they are going to cause a dry mouth because of M3 blockade in the salivary glands. And next you have a promethazine, which is also a highly potent antihistaminic agent. These are used in case of allergic conditions. But the side effect is, since it crosses the blood-brain barrier, it belongs to the first generation antihistaminic agent, it can lead to sedation. So whenever you are prescribing these drugs, you should be very careful. The person should not indulge in any conscious activities, the activity which requires constant attention. And next we have a diclofenac. As we discussed, NSAIDs, the paracetamol will going to produce analgesic as well as antipyretic effect, which is a desirable effect, but the side effect will be your gastric irritation. So next, coming to the secondary effects. So what do you understand by secondary effects? So secondary effect is nothing but the extension of the pharmacodynamic action. So these are the indirect consequences of the main pharmacodynamic action. So let us take an example. So you can see the example here. So whenever you take a antimicrobial agent, so One thing you should remember is all this antimicrobial agent will going to cause damage to the normal intestinal flora in the intestine. So whenever the antibiotic erodes or wash away or removes the normal intestinal flora, what will happen in the gut? There are both bad as well as the good microbials. Whenever you give a antimicrobial agent for a prolonged duration of time, not for a therapeutic duration of time, whenever you administer a antibiotic for a prolonged duration of time, what happens is this good epithelial which is present will be eroded, giving a opportunity to the bad microbial or the pathological organism to produce its effect, leading to the super infection which can lead to diarrhea, etc. And one more very important drug, a very magical drug which was used in COVID, that is corticosteroids. When it is used in a untoward doses, it can decrease the immunity. So when it is used for a particular duration of time, it can act as a wonder drug, but if it is misused, it can decrease the host immunity, and this can cause opportunistic infections. So next we have a toxicity. So toxicity is the extension of the side effects. Extension of the side effects means, so side effect was occurring at a normal therapeutic dose, whereas toxicity will occur at the overdose or whenever the drug is given for a prolonged duration of time. And one such example is atropine poisoning. So this is the pharmacodynamic reasons where the patients will have experience like delirium, hyperpyrexia and hallucination. Whenever you give atropine, where do we give atropine? Atropine is a drug of choice for organocompound poisoning. So whenever the drug exceeds, so whenever after the atropinization, if the drug is continued and if the dose goes to the maximum tolerable dose, the patient will experience these effects due to the overdose. And next you have other pharmacodynamic mediated toxicity, that is heparin. Heparin is anticoagulant. So one of the very important side effects or most common side effect, and you need to go to monitor the blood levels with respect to the heparin. So heparin will going to cause bleeding as a side effect because it's anticoagulant. You need to monitor all the blood parameters. So next is the barbiturate, which is seen as depressant drug. So this overdose can lead to unconsciousness as well as the coma. And pharmacokinetic mediated toxicity or sulfonamides. So sulfonamides are the most dangerous drug which can lead to hypersensitivity reaction. So whenever these drugs are taken, the patients will be asked to consume more and more water so that the crystal formation will be avoided and it will decrease the stone formation. So one of the side effects of sulfonamide toxicity is crystalluria as well as glomerulonephritis. And one more drug which can lead to nephrotoxicity is the gentamicin. Next we have a type B adverse drug reactions. So in case of type B adverse drug reactions, we have a drug allergy or a hypersensitivity reactions. As we discussed, it is one of the type of type B adverse drug reaction. So whenever you think of hypersensitivity reaction, it comes under type B adverse drug reaction. So when do we call it as a adverse drug allergy or hypersensitivity reaction? So whenever there is a previous exposure to any of the antigen or a drug, the body immune system will going to sensitize, and re-exposure of the same drug will going to cause a similar reaction, and reaction severity will be more if it is exposed to the drug frequently. So here what happens is, here you can see that drug will act as a heptons which will be combining with the host proteins to become a antigenic. The drug itself will not be antigenic. The drug acts as a epton and it will going to combine with the host protein to become a antigenic, and these antigens will going to uh, cause antibody production. It will going to evoke the antibody stimulus from the beta cells, and the specific antibodies to that particular antigen will be released and it is going to circulate. So again, when you administer the same drug, so there will be re-exposure of the same drug. Already the antibodies are present in the circulation. These lead to antigen-antibody responses, leading to the release of the chemical mediators like histamine, serotonin, leukotriene, and SRSA, and platelet activated factors, which are the inflammatory mediators. This can lead to hypersensitivity reaction like fever, rashes. They can cause generalized edema. There can be a difficulty in breathing, etc. So what are the examples we can quote here? The patient will have urticaria, rhinitis, patient will have pruritus, they can have asthma because of bronchoconstriction and anaphylactic shock. Anaphylactic shock will have a wide variety of symptoms like rashes, especially the difficulty in the breathing. There will be inflammation of the larynx as well as there will be contraction of the bronchial smooth muscles. So there can be laryngospasm as well as bronchospasm. So next, coming to the types of hypersensitivity reactions or types of drug allergy. So here you have type 1, type 2, type 3 as well as type 4 hypersensitivity reactions. So type 1 is also called as immediate type, which is also a humoral antibody mediated reactions. Type 2, which is an accelerated allergic responses, it's antibody dependent cytotoxic hypersensitivity reaction. Again, it is a humoral antibody mediated reactions. Whereas the type 3, it's an immune complex mediated reactions, and example is serum sickness. And type 4 is a delayed type, or it is also called a cell mediated hypersensitivity reaction. So among these 4 types of hypersensitivity reaction, the first 3, type 1, type 2 as well as type 3 are humoral mediated responses, whereas the type 4 is the delayed, or it is the only cell mediated responses. The only cell mediated responses is the type 4. Other 3 are humoral antibody responses. So how do you remember this 4 types in a very easy and convenient manner? So you can remember that type 1, 1A, it's a anaphylactic reaction. A stands for anaphylactic reaction, is a type 1. 1 you can remember it as, it look like I, so it is an immediate type of responses. Next, type 2, you can remember it as B. So alphabetical B is the second word, second letter, and B stands for body, antibody dependent cytotoxicity. Whereas type 3, so type 3 in the alphabeticals, type 3 is C. So it is complex mediated, it is a complex mediated. So and next in the letter is D, that is a type 4 delayed hypersensitivity reactions. A, B, C, D. A stands for anaphylaxis, which is immediate type. B stands for body, antibody mediated cytotoxic hypersensitivity reaction, and 3 stands for, that is C, complement mediated, and the last letter D, which is a type 4, is a delayed type of hypersensitivity reactions. So let us see this individual adverse drug reactions. So usually the type 1 reactions develops within a minute, very quick response will be there. So the reactions will occur very quickly within 2 to 3 hours following the administration of the drug, and these are through the IgE mediated antibodies. So tissue sensitization to the IgE immunoglobulin antibodies will occur. So thereby, So there will be tissue sensitization of IgE antibodies which are present on the mast cell and the leukocytes, mast cell and the leukocytes. Again, the same concept you should need to understand. Again, if there is a re-exposure of these drugs, the mast cells which are carrying the sensitized IgE antibody will get activated, and this will lead to activation of the mast cells, leading to mast cell degranulation, release of the chemical mediators, and simultaneously it can activate the leukocytes also, and there will be release of chemical mediators as we saw in the previous slide. There will be release of histamine, leukotrienes, SRSA, etc. And example for type 1 hypersensitivity reaction is anaphylactic reaction or anaphylaxis, which is an immediate type of reaction. So this type of reaction can occur following the administration of penicillins, streptokinase, and their radio contrast materials. So one of the very common reaction that can occur with respect to the administration of penicillin is hypersensitivity reaction or anaphylactic reaction. That's why whenever we talk about penicillin administration, we think of the test dose. Before administering, we need to give a test dose to check for the hypersensitivity reaction. So next comes the type 2, that is B, body antibody dependent cytotoxicity reaction, which occurs within the 72 hours, and again when we saw the type 1, it was IgE mediated, whereas type 2 is IgG antibody mediated. So IgG antibody as well as drug which acts as an antigen forms a complex and it binds to the RBCs. So once it binds to the RBCs, what will happen is antigen antibody reaction takes place, leading to the lysis of the RBCs. So how lysis occurs? Through the complement system as well as cytotoxic T cells, are either the phagocytosis. And the example which we can quote for type B is due to the lysis of the RBCs, it can lead to thrombocytopenia, agranulocytosis, hemolysis, fever, and systemic lupus erythematosus. So these type 2 reaction can occur following the administration of the drugs. You can see here drugs, that is those are the quinidine, cefotetan, which are the cephalosporins, and the penicillins. And next come to the type 3. Type 3 means C, complement mediated. It's an immune complex mediated, which occurs almost type 2 and type 3 look similar, but little bit differences are there. So type B was occurring within 72 hours, whereas type 3 is occurring after 72 hours. Type 2 is occurring before 72 hours. Type 3 reactions are occurring after 72 hours, but within 1 to 2 weeks. Again, the IgG antibody and will combine with the antigen. Here also it binds to the RBC, but in the RBCs they bind to the vascular endothelium. So these complexes get deposited on the vascular endothelium, and it will lead to activation of the complement system, leading to the conditions like serum sickness and glomerulonephritis. The differentiation here is the duration. Type 2 reaction occur within 72 hours, type 3 reaction occurs after 72 hours. And this occurs following the administration of ampicillins, non-steroidal anti-inflammatory agent, as well as sulfonamides. So next, coming to the what symptoms you are going to see in serum sickness, you are going to see fever, urticaria, and lymphadenopathy. With this, you can make a diagnosis of serum sickness or type 3 hypersensitivity reactions. So coming to the type 4, which is rest of them were humoral mediated. Only the type 4 is cell mediated hypersensitivity reaction, which is delayed. So delayed means it will be taking much time. So whenever there is a contact of antigen, whenever the antigen comes into the circulation, that is a drug, the T cells will get sensitized. So once the T cells get sensitized, The activated T cells will going to release the again the cytokines. So these cytokines are very very dangerous. It can lead to inflammatory reactions. So again the release cytokines like interleukins, tumor necrosis factor will activate the macrophages, granulocyte, natural killer cells, and you can see even the uh, other inflammatory mediators will be activated, leading to the inflammatory responses. The example here is, you can see the example for delayed hypersensitivity reaction is delayed dermatitis, contact dermatitis, hypersensitivity pneumonitis, photosensitivity, rash with fever. So just a summary of this, how to remember. Type 1 is an immediate type of response, which is humoral IgE mediated. Anaphylaxis is the which occurs following the administration of penicillin. Or type 2, again antibody mediated, which occurs less than before the 72 hours, and which is IgG mediated. Example is SLE and hemolysis, which occurs following the administration of penicillin and cefotetan. Next we have a type 3, which is C, that is the complement mediated or the immune complex mediated, which occurs after 72 hours, and again this is mediated by IgG. Example is serum sickness, which occurs following the ampicillin and non-steroidal and anti-inflammatory drugs administration. And next we have a type 4, that is D, delayed type of responses, which is only this type of reaction. Type 4 is only mediated by cell mediated. Others are mediated by humoral. Example is contact dermatitis and photosensitivity reactions. Coming to the anaphylactic shock. Whenever you come across the anaphylactic shock, please remember it is emergency. It is very very emergency, because it's an immediate type of hypersensitivity reaction, and the patient may die also because of laryngospasm and bronchospasm, and also the BP will come down. So there will be hypotensive shock, there will be bronchoconstriction due to the inflammatory mediators. What they will do on the bronchus, it will going to contract the bronchial smooth muscles. There can be angioneurotic edema, there can be laryngospasm, and patient, if unattended, immediately the patient will die. So what is the treatment for anaphylaxis? So the treatment for anaphylaxis is drug of choice. Please remember A for A. Anaphylaxis A. Again the drug of choice will be the A, which is the drug that is adrenaline. So A for A. Anaphylaxis, the drug of choice is adrenaline. The other name for adrenaline is epinephrine. So since it is an emergency condition, you need to give it through parenteral route, that is the injection form. Injection adrenaline, even the ratio is defined. The ratio has to be 1:1000. What will be the dose? 0.3 to 0.5 ml. Which is the route preferred? The route preferred will be your intramuscular route, not subcutaneous, not IV. Why not subcutaneous? In subcutaneous, what happens? Already when a patient is in shock, what happens to the peripheral vasculature? The peripheral vasculature will be constricted. What will happen when peripheral vascular are constricted? So constricted means, even if you give the drug through subcutaneous route, to reach the systemic circulation, it takes very long time, and we lost the opportunity of that good time to save the patient. So you need to give through intramuscular route through the lymphatic system. It will go into the systemic circulation very quickly, and the dose has to be 1:1000. Why not through IV? You can give it through IV, but the two drawback is you need to dilute the adrenaline. So you need to make a dilution of 1:10,000. The patient is not able to get administered through intramuscular route, you can go with the IV route. Only condition is you need to increase the dilution to 1:10,000. Why you need to increase the dilution? Because there is a risk of arrhythmias when you give it through intravenous route. So that's why always prefer through intramuscular route in a form in the dilution of 1:10,000. 1000, if it is not able to give it through the intramuscular route, you can give it through intravenous route, but you need to increase the dilution to 1:10,000, and you should be very careful and look for ECG changes for any arrhythmias. Along with that, why adrenaline is given? So adrenaline has got action on the beta 2 receptors as well as alpha 1 receptors. Alpha 1 agonism will cause vasoconstriction and it can lead to increase in the blood pressure. So there will be hypotension. So these drugs will going to rise the blood pressure. And bronchospasm can be treated or it can be relieved by the action of the adrenaline by acting to the beta 2 receptor present in the bronchial smooth muscle. Beta 2 will cause bronchodilation. So thereby it will also reduce the secretions also. The next comes to the hydrocortisone, which is a wonder drug, 100 to 200 milligram IV it has to be given. It can be repeated mainly because of their anti-inflammatory property. It will going to reduce all the inflammatory mediated reactions. And next is the injection diphenhydramine. Sorry for the spelling mistake. It is diphenhydramine, not S. Instead of S, there should be A. So diphenhydramine, which is an antihistaminics. Even in anaphylaxis, there will be a rise in the histamine levels. To counter-react this histamine-mediated bronchoconstriction, you can go for injection diphenhydramine 25 to 50 milligrams intramuscularly. And what are the treatment for other types of hypersensitivity reaction? We have type 2, type 3, type 4, all type 2, type 3, type 4. The best drug is corticosteroids. That is hydrocortisone IV or prednisolone IV. Next, coming to the genetically determined abnormal responses. Till now we talked about the one of the type B mediated allergic responses, that is hypersensitivity reaction. Next comes the genetically mediated abnormal responses. So it's unusual response to a drug because of the genetic polymorphism. Individual genetic nature will be very, very different. So based on the genetic setup of an individual, the individual will going to react to the drug administered. So each individual will respond to the drug in a different way. So there are some examples to remember. Pharmacogenetic variation which occurs in the phase 1 drug metabolism, during phase 2 drug metabolism, or due to enzymatic deficiency. Let us take up one by one. So pharmacogenetic variation with respect to the phase 1 drug metabolism, there are atypical pseudocholinesterases as well as hydroxylase polymorphism. And phase 2 mediated drug metabolism, we have a astylator status, like some of the individuals will have fast astylators, some of them will have slow astylators, etc. And pharmacogenetic variation due to the enzymatic deficiency, one of the classical example is the glucose 6-PD deficiency as well as uroporphinogen synthetase enzyme deficiency. Now coming to the atypical pseudocholinesterases. So it belongs to the phase 1 drug metabolism, where this type of condition is seen in 1 in 2500 individuals, and there is an inheritance trait and is an autosomal recessive condition. So whenever you give a succinylcholine which is a skeletal muscle relaxant, it has to go metabolism or it has to be broken down by an enzyme called as pseudocholinesterases. Normally what happens is, if the pseudocholinesterases are normal, succinylcholine actions will be terminated within 5 minutes by the hydrolysis by the pseudocholinesterases. If there is atypical or abnormal pseudocholinesterases, the succinylcholine will not get metabolized, will not be broken down, and succinylcholine concentration will remain same. So one of the drawback of skeletal muscle relaxant is, if the skeletal muscle relaxants succinylcholine concentration remains in the body for a prolonged duration of time, it can prevent breathing because it is a relaxant. It can stop breathing also. You should be very careful. It can cause succinyl choline apnea because of the diaphragmatic muscles will be paralyzed. So in case of atypical pseudocholinesterases, succinyl choline will not be hydrolyzed. It may take 1 to 2 hours. So at the same therapeutic dose, with an individual who are having atypical pseudocholinesterases will going to experience the prolonged respiratory failure. So how we can measure the atypical pseudocholinesterase level? So you can measure it by the measurement of the quantity of inhibition done by the Debukane, which is a local anesthetic. So Debukane numbers are taken to measure the levels of atypical pseudocholinesterase in the body. So Debukane basically inhibits pseudocholinesterases. Normally Debukane will inhibit 80% of the pseudocholinesterases. In case of atypical or genetically altered pseudocholinesterases, it will only inhibit 20% of the pseudocholinesterases. So therapeutic doses in such condition lead to prolonged respiratory failure. So the Debukane number will give whether this patient is having a risk for succinyl choline induced apnea or not. So it measures the percentage inhibition of the plasma choline esterases. So normal Debukane number will be the 80 because it inhibits 80% of the pseudocholinesterases. And in case of atypical pseudocholinesterase, it only inhibits 20. So normally level should be, Debukane number should be 80. So coming to the hydroxylase polymorphism. So please remember this is a type, again phase 1 drug metabolism reaction. The example is phenytoin. Phenytoin will going to undergo hydroxylase as well as the oxidase reaction. Faulty enzyme or the faulty hydroxylation process will lead to slow hydroxylators. Phenytoin will get concentrated, phenytoin will get accumulated, leading to increase in their plasma concentration that can lead to toxic responses. Next we have a acetylator status, which is very important with respect to one of the antitubercular drug, that is INH, isoniazid. It's a type 2 or a phase 2 drug metabolism. So there is an N-acetyl enzyme in a liver which helps in N-acetylation, and there are rapid acetylators and there are slow acetylators. So rapid acetylators we have are seen in Eskimos and Japanese, whereas slow acetylators are seen in the Egyptians, Mediterranean Jews as well as Swedish. So what happens here? Whenever an individual is having rapid acetylation process, what will happen to the drug concentration? Drug concentration will be very low, and that drug will not be sufficient to produce its therapeutic effect. What happens if the patient are having slow acetylator status? In such condition, the same drug, what will cause is increase in the concentration in the plasma, because of the slow acetylation process, drug will remain for a longer time, that can lead to the toxicity again. So example is isoniazid and dapsone, which will undergo acetylation. So rapid acetylators, whenever you give a isoniazid, it can lead to accumulation and can lead to neurotoxicity and peripheral neuritis. So this can be treated by giving isoniazid along with the pyridoxine, vitamin B6. So neurotoxicity or peripheral neuritis can be prevented by co-administration of pyridoxine along with the isoniazid, which is a very popular antitubercular drug. Slow acetylator status, again the concentration will going to build in the body. This can going to affect the liver, that is hepatotoxicity. Coming to the G6PD deficiency, again this is the one of the classical example for pharmacopolymorphism. So in individuals who are having G6PD deficiency, if you administer drugs like especially drugs which are used in malaria like quinine, chloroquine, it can lead to hemolytic anemia. There will be lysis of the RBCs, Next we have a uroporphyrinogen synthetase enzyme deficiency. So this enzyme deficiency will lead to increase in the concentration of the phenytoin, chloramphenicol and oral contraceptive pills, and these drugs will going to precipitate the intermittent porphyria. And next, coming to the idiosyncratic reaction. So as the name suggests, the idiosyncratic means the cause of the reaction is not known at all. The cause is unknown. Example is malignant hyperthermia or malignant hyperpyrexia. So this can occur with whenever you give a drugs like halothane, succinylcholine and alloperidol. And one more example is when you give a chloramphenicol, it can lead to aplastic anemia. And when you give aspirin, some of the sensitive individuals, aspirin induced late onset asthma can occur due to the increase in the leukotriene levels in the body, and thiazide induced erectile impotence. So what is the drug of choice for malignant hyperpyrexia or malignant syndrome? There will be increase in the calcium levels. There is abnormality in the ryanodine receptors. Yes, the drug of choice will be your dantrolene sodium, which are the ryanodine receptor antagonist, which is an antidote for malignant syndrome or malignant hyperthermia. Next, we have a type C adverse drug reaction. Type C stands for chronic effects. Whenever you give a corticosteroid, prednisolone, for a longer period of time without tapering the dose of the prednisolone, what will happen is Cushingoid effects. Aspirin, long-term administration, any NSAIDs will going to affect the kidney, leading to analgesic nephropathy. Phenothiazones, orofacial dyskinesia, again the extrapyramidal side effects. Type D adverse drug reaction, D stands for delayed effects. This can be seen with respect to whenever you administer a alkylating agent. When you are going to treat Hodgkin's lymphoma, this can create a secondary cancers. Again, administration of the diethylstilbestrol in a pregnant woman, it can lead to clear cell vaginal carcinoma in the female offsprings. Next, we have a type E adverse drug reaction. E stands for end of treatment effects. Whenever you suddenly stop any kind of drug, it can lead to again a danger effect. You are giving a propranolol or you are giving any antihypertensive drug. If you suddenly stop any antihypertensive drug, there will be rebound hypertension. And whenever you stop the prednisolone or corticosteroids immediately or abruptly, it can lead to adrenocortical insufficiency. And phenytoin withdrawal, which is an anti-epileptic drug, it can lead to precipitation of the seizures. Next, we have a type F ADR, that is a failure of drug. So there can be polymorphism of drug targets. Even if you give a drug, the drug will reach the target but not able to either activate or inhibit the target site because of the polymorphism in that receptor or enzymatic conformation that leads to the failure of the drug response. Coming to the iatrogenic disease. So iatrogenic disease is the drug induced diseases or disease induced by the drug, or it can be called as physician induced adverse drug reactions. So example is glucocorticoids can lead to hypertension, can lead to development of the diabetes mellitus also. Aspirin, NSAIDs, again it will going to reduce the prostaglandin, gastroprotective prostaglandin secretion in the stomach, which maintains the mucus layer. This aspirin being the NSAIDs, it will going to inhibit the prostaglandin secretion in the stomach, leading to increased risk for peptic ulcers. And chlorpromazine, again it will going to block the D2 receptors and lead to Parkinsonism. So in summary, we talked about the definition of the ADR, adverse drug reaction. So it is an unintended effects which will be seen at the normal therapeutic doses, which are used for either prevention or the treatment or diagnostic purposes. So there are broadly two types of ADRs, type A as well as type B. Type A is augmented, type B is bizarre reaction. Type C is the chronic, type D is the delayed, type E is the end of treatment reactions, type F is the failure of the drug to produce desirable effects. And we also talked about the or treatment for anaphylactic reactions. So the drug of choice for anaphylaxis is adrenaline, 1 is to 1000, 0.3 to 0.5 ml. Route preferred is intramuscular route. Along with that, you can give hydrocortisone IV as well as diphenhydramine, which is an antihistaminic agent, through intramuscular route. So this was all about the class on adverse drug reaction. If you have any doubts, you can clear it. Hope you have understood a concept of adverse drug reaction, what are the types of reaction and what are the examples for reaction, to identify it and how to treat the anaphylactic reaction. Thank you.